Welcome to Season 7 of The Common Bridge, hosted by Richard Helppie, a leading analyst, philanthropist, and entrepreneur. Now expanded with healthcare, education, finance, science, and world affairs bridges, the podcast, now in its 7th season, with an audience of over 7 million worldwide, explores issues in a fiercely nonpartisan way. Find us at The Common Bridge at substack.com, YouTube, and wherever you listen to your favorite podcasts.
Hello, welcome to The Common Bridge. I'm your host, Rich Helppie, and today we've got a great guest. With us today in studio is Dr. David Miller. Dr. Miller is a physician. He is the Chief Executive Officer of Michigan Medicine here in Ann Arbor, Michigan. He is also the Executive Vice President for Healthcare at the University of Michigan. And so we're going to be talking about healthcare today as we continue to investigate, inform, and probe what's going on in the healthcare delivery system. Now, if you think about healthcare, it is the largest economic sector in the largest economy in the history of the world. And we spend a lot of time talking about the business model and how the money flows and who's making money and who's distressed. But bear in mind that at the heart of healthcare is helping people stay well, applying diagnoses, and treatment for those that are sick and injured. And as former Senator Fritsch, who was also a physician, a heart surgeon, said, all families have issues, but if a person is sick, then the family has one issue. So today we're privileged to talk to Dr. David Miller from the Michigan Medicine. Dr. Miller, welcome to The Common Bridge. It's really a pleasure to have you today.
Thank you, Rich. I'm really grateful for the opportunity to be here with you today and looking forward to our conversation, and deeply grateful for the opportunity to talk about our extraordinary teams at Michigan Medicine.
Well, you do life-saving work there every day and in some research, and I know our listeners, readers, and viewers are going to be fascinated to hear that. But tell me a little bit about yourself. Where were your early days? What did you do? What led you to your career as a physician and now as a executive leadership?
Thanks, Rich, very much. Well, I'd start by saying I'm a lifelong Wolverine. I often say that when I was very young, I shared a bedroom with my brother in Midland, Michigan, where we grew up, and we believed we were the first and second biggest Rick Leach fans in the state of Michigan when he was the quarterback at University of Michigan. And so I've been connected to the university really for my whole life, and have a deep love and appreciation for the university, for the state of Michigan more broadly. As you mentioned, I'm a urologist. My clinical background is in caring for patients with urologic cancers. And currently my practice focuses on taking care of patients with prostate cancer. And that continued presence in clinical care delivery is really important. I love taking care of patients. It's fundamentally what we do, and it keeps me deeply connected to the work of our organization. In terms of my journey to this particular position, it's probably some combination of serendipity and planning. I started my career trying to build a practice, taking care of patients, doing research almost as a clinician scientist at the university, writing grants to the NIH, building a research program, publishing papers, a lot about thinking about quality of care for patients with urologic cancers. That led to some opportunities to begin to work on quality and safety across our growing statewide system, including our partnership with My Michigan Health in Midland, where I grew up and where my dad was a physician for many years. Ultimately into some operational leadership roles coincident with the pandemic that gave me a much broader view on the opportunities and challenges in healthcare delivery here at Michigan Medicine and more broadly. And now the great fortune to be in the CEO role and EVPMA role, and really having the opportunity to say across all of our missions of clinical care, research, and education, an academic health system should draw strength at those points of intersection between research, education, innovation, and clinical care. And how can we really be an asset for the state of Michigan and beyond? After all, our mission is to advance health to serve Michigan and the world. And I often say that concept of advancing health is a commitment to continuous improvement in the work we do every day, access in the healthcare delivery space, safety and quality, and then to serve Michigan and the world. I believe we have a statewide opportunity and responsibility to help bring our expertise and services to as many communities as possible, and then to innovate to advance the field more broadly. And the last thing I'll say is I often reference my having grown up in Midland. Alden Dow was an architect in Midland who talked a lot about the built environment and the concepts of honesty, humility, and enthusiasm. And I would just say those are the leadership attributes that I've tried to apply along the way. Honesty, foundational for any effort at leadership. Humility, because you face difficult circumstances and decisions. And if you have humility, your team will stay with you during those ups and downs. And then enthusiasm, because despite the challenges in healthcare delivery, as you said, and as I think you referenced, Dr. Frist, in that moment when patients and families are facing a healthcare issue, it is the single most important thing on their agenda. And despite the complexities of the business side of healthcare, the technology that now infuses every aspect of healthcare, it remains fundamentally and essentially human.
It's miracles.
It's people taking care of people.
Yeah, it's a miracle of modern medicine, and the expectation that anything can be cured. And in your area of specialty, that was a debilitating or deadly disease, and we've all known many people, you many more, that have survived it. Nate Kaufman and I talk often on the Common Bridge and on the Healthcare Bridge about the need for clinically oriented people, doctors that are influencing healthcare policy. And in Washington, in Lansing, and often at the heads of healthcare delivery systems and health insurers, you can't find a physician around. And, just makes sense that, if you're running a car company, you want engineers, right? If you're running a technology company, you want data scientists. And it stands to reason that we should have more physicians that have followed your path. Now, I know Michigan medicine is a big place, of course, anchored by the world famous University of Michigan Hospital. What are all the components of Michigan medicine today?
Yeah, thanks. And I'll just mention yesterday we celebrated the soon to be opening of our new inpatient tower, the D. Dan and Betty Kahn Healthcare Pavilion, and we're very excited about that. And so if we then zoom out and say Michigan medicine as a whole, it really represents what I call our full academic health system. So it's inclusive of the University of Michigan Medical School celebrating its 175th anniversary this year of extraordinary education, innovation, and leadership. And then our clinical delivery system, which we reference as University of Michigan Health. So Michigan medicine includes University of Michigan Medical School and University of Michigan Health. University of Michigan Health then comprises all the elements of our academic medical center here in Ann Arbor, our adult hospitals, children and women's hospital, the cardiovascular center, the new D. Dan and Betty Kahn Healthcare Pavilion, and all of our ambulatory facilities that you see in the community, West Ann Arbor, East Ann Arbor, Northville, Brighton, the newly announced facilities in Troy. And then it also includes our regional health system. So our member systems in Lansing and in West Michigan, University of Michigan Health Sparrow, which is 6 hospitals and many ambulatory sites in mid-Michigan, and University of Michigan Health West, our hospital in Grand Rapids and its ambulatory sites. So it is that in totality, Michigan medicine is the medical school plus all the elements of our clinical delivery system across the state. 12, I think it's in total, 12 hospitals, hundreds of ambulatory sites, 30,000 incredible employees working to kind of advance our mission across the state.
And then also affiliations like Traverse City, Midland, Chelsea, and elsewhere, spreading the outstanding work that you do to more places outstate.
Yeah, no, thanks, Rich. And what I reference are the kind of fully integrated members of our system, but you're absolutely right. Our goal is partnership as another way of kind of enhancing impact. And so strong partnerships with My Michigan Health in mid and northeastern Michigan, our partnerships with Trinity here in southeast Michigan, including our partnership at Chelsea Hospital, where we're very proud of our presence in the community. And in West Michigan, we have partnerships in cancer and cardiovascular networks with Trinity. So and then we have clinical partnerships with many other systems in the state, including, you mentioned, growing partnerships in clinical programs with Munson Healthcare. So we are trying to support community-based access to services at the level that Michigan medicine can provide across the state, really consistent with our mission.
And also, Michigan is known as a world-class research center, and I would imagine that oftentimes somebody has a unique disease that is being researched at Michigan, and they might look at, Memorial Sloan Kettering or MD Anderson or Cedars-Sinai or Mayo Clinic, and then say, gosh, the best care is at Michigan. They could be coming from any place in the world.
Yeah, no, I think that's great. And, we have a tripartite mission. Research and education are in our DNA. And I think as you think about where healthcare is going, some new and emerging curative therapies, whether in gene therapy or cellular-based therapies for cancer, for autoimmune diseases, the availability of the science and innovation side of that, access to clinical trials, the ability to administer new and emerging complex therapies. We really think that's one of the key differentiators of Michigan medicine in the state and nationally, as you mentioned, a number of our peer academic medical center organizations. And I'll give you an example where we're really starting to try to capitalize on that capability. We know, for instance, for patients with advanced cancer, that up to 70% of those patients have, if you could do what we call a next generation sequencing, understand the actual types of mutations in the tumor, that up to 70% of those patients have what we call an actionable change, something that would benefit from a specific medication, but a much smaller proportion are actually getting that testing. We're now working to set up an infrastructure that would greatly increase access to that testing, which would not only help identify better treatments, but pair that with understanding accessibility to clinical trials. That's where we see a real opportunity to harmonize one aspect of the research we do along with our clinical care. And I'll give you one final example. Last week, I visited the research symposium for our postdoctoral fellows in molecular and cellular pathology. And it was remarkable, the work that's being done now, really at kind of the foundational understanding of genetic and molecular changes, and how those not only help us identify the next generation of treatments, but understand who will respond and benefit from those. Where the fields are going now was really represented in that seminar, and I think Michigan medicine will be at the heart of that moving forward.
That is fascinating. And as a non-clinical person, when someone explains to me about gene editing, that somebody has a particular condition and it's the gene's identified, we know the variant in the gene, and that there's a method for removing that gene, fixing it, putting it back in. So when cells are generated, it is not carrying the disease anymore. It's an amazing thing. And that research is lengthy, it's time consuming, it's very expensive. Research funding. And, in the current administration, we've heard some of that research funding is at risk or suspended. Where does the source of research funding come from? And has there been any impacts with the current presidential administration?
Yeah, thanks. It's such an important question, and I'll start with the observation. I mean, what you referenced, kind of these new emerging gene-based therapies. It's incredible because the concept of having curative opportunities, many of these are conditions that present in childhood, has transformative potential. And so, how do we continue to support discovery, which is at the heart of what we do at Michigan Medicine and at the university more broadly? Just in the medical school alone, we have close to, in total, $800 million of annual funding from the NIH every year. And an incredible group of faculty, investigators, and trainees that we need to kind of sustain, support, and continue to help build their careers and impact. And so the current environment has been challenging. And look, I will be the first to say we have had a long and positive and impactful partnership with the federal government to support research, and we seek to continue that. We know that whether the changes have been in timing of the release of the budget and appropriations to the NIH, whether it relates to so-called indirect costs and how those are allocated to support research infrastructure, those are points of uncertainty that exist in the research environment. We continue to advocate for the impact of research like the efforts done at University of Michigan. When you look at most FDA-approved medications, at some point they've been evaluated through NIH-funded research. We have to tell the story of that impact, and then we have to advocate for it. Now, we know that if you look, for instance, at funding, actual dollars allocated from fiscal year 25 to fiscal year 24, the decrease in that total dollar amount has been modest for Michigan medicine, and we're grateful for that. What has changed is the total number of grants has decreased a little bit. So we're looking at that and how do we continue to support our investigators who are submitting excellent science during this moment of uncertainty, keep their work going, even as we have important conversations about budget allocations, indirect costs. So we are going to continue that work and really find ways to continue to support our investigators. And we're doing that both at Michigan Medicine, with the campus more broadly, and as part of advocacy for biomedical research in higher ed. And I'll give you one story that tells why this is so important. Just in the last couple of years, there's a technology called histotripsy that was actually emerged as a partnership between the College of Engineering and the medical school, a new mechanical approach to ultrasound treatment, non-invasive treatment of tumors, FDA approved now for treatment of liver tumors, now being disseminated not only nationally, but also internationally, and culminating in a big exit for the company Histosonics that started out of the research done at the University of Michigan. And that level of connectivity between the innovation, the research and development, the clinical assessment, and then the dissemination to scale, not only in Ann Arbor, but in Grand Rapids, and now moving across the country and the world. That model is something that we have to be committed to replicating, that we need the continued support and partnership with the federal government.
And the alternative treatment, we're talking chemotherapy, surgery, liver transplants versus non-invasive ultrasound treating of liver tumors?
Yeah, I mean, it's, and again, the data around the long-term impact continues to emerge. But when you think of it from a patient perspective, a very difficult, complicated situation of cancer that has either originated or spread to the liver, the treatment options that exist have been much more invasive with higher risk. This is really a non-invasive, very low side effect profile treatment that is showing very early promise. And so that type of approach, right, an innovation based in the best available science, connected to a clinical delivery system, made available to patients broadly in a way that lowers the potential risks of treatment, is a model we want to pursue over and over.
It's the epitome of the three-part mission that you have at Michigan Medicine. And Dr. Miller, when I hear these kind of things, it's very exciting. And I'm sure all of our listeners, readers, and viewers are going to be excited about these breakthroughs in medicine. And, I'm a simple guy. Look at, all right, we have people that want wellness, they want diagnostics, they want treatment, right? And we have this amazing delivery system to provide that wellness and that diagnostics and this treatment. But when you look at, from your role as a leader of a health delivery system, what are the pressures facing you, and what are the differences between a community-based system or a faith-based system or an academic medical center?
Thanks, Rich. I think it's a really important question. And I mean, I think if you look at healthcare delivery more broadly, I always say in that mission of advancing health to serve Michigan and the world, the concept of advancing health means we as a academic medical center, academic health system, have to acknowledge that we're imperfect in some ways. Mm-hmm. And we have to continue to improve concepts like access. How long does it take for patients to schedule an appointment? How long does it take to answer the phone when you call? How do we ensure that we're balancing access to primary care with the specialty care? So I think for us, ensuring better access, I say a broader and more welcoming front door, that even as we grow and expand, we're ensuring that safety and quality measured by external factors and by the excellence of our clinicians continues to be preserved. And doing that in a way that also ensures an excellent experience for our patients and our team members. Those are complex dynamics. As you grow, as you face the demands we have with constraints and capacity in other areas, finding that balance between improving access, ensuring safety and quality, managing experience are our operational challenges. And we have a set of strategic priorities we call building our base: belonging, access, safety and quality, and experience, and how we enhance both our measured performance and our stories in the organization in all those areas. But then we do that, Rich, in the context of a complex regulatory and financial environment. Healthcare systems run on relatively small operating margins in a highly regulated, highly complex organization. And if you ask most CFOs or leaders of healthcare systems, they tell you in the last 5 years, the revenue and expense curves are crossing, if not, if not converging. And so how do we continue to have a financial operating model that allows us to invest in our programs and our teams and in our facilities? So one distinction between an academic medical center and a community-based health system is that investment in education and biomedical research. The clinical enterprise for Michigan Medicine and University of Michigan Health is an important engine in those investments in the medical school and biomedical research, which means we have competing constraints for other capital investments, whether they might be strategic capital or routine or replacement. At the same time, the relationship between community-based health systems and academic medical centers can be very positive. And I think an example of that is here in Washtenaw County, where with Trinity, we have an excellent community-based health system that's providing great primary, secondary, and tertiary care, but allowing for, we hope, continuously easy interactions and movement for patients in some scenarios where the higher complexity services at the academic medical center are available. And then using the example of Chelsea Hospital, that one of the great community-based assets can be a site of partnership where services for patients who might be being referred to Michigan Medicine from across the state can get care in the right environment, right?
They're inpatient rehab.
Exactly. They're lower complexity care in an environment that's very used to, efficient, and easy to receive that care in a high quality, safe setting. And then to have particular programs like inpatient rehabilitation where you can really build a center of excellence. So there are differences, there are points of connectivity, and finding the ways to collaborate has been one of our commitments.
You mentioned education and the medical school, and training physicians is different. So several years ago, we were looking at the numbers, and the same number of physicians were retiring as were entering practice, but those retiring were 75-hour-a-week physicians, and those entering are 45-hour-a-week physicians. And then beginning in the 1990s, the supply of physicians was restricted with the graduate medical education budgets being severely cut. So when you look at that mission of training doctors and other caregivers, what are some of your challenges today, and what's Michigan Medicine doing about making sure we have enough doctors?
Yeah, it's a great question. And, I'll start by, I won't remember the exact numbers, but Dr. Lou Edge, who's one of our deans leading all of our educational programs at the medical school, often references the pace with which medical information is doubling. Back at around 1950, it was estimated it was somewhere around 50 years. By 2020, that had decreased to about 70 some days, and now is even less than that. The pace with which medical knowledge is proliferating is extraordinary. It's almost breathtaking. And so how do you prepare the next generation of students to practice in that environment? And I think one of the things that Dr. Edge, and we're extremely grateful that we've recruited an incredible new dean for our medical school, Dr. Tommy Wang, that we're thinking about at the medical school is how do we better prepare students to learn and to practice in that environment, particularly in the setting of new technology, generative AI, and other areas. And I think there's this concept of building AI or technology fluent students through curriculum revisions that support that, right? How do we think about in the clinic using technology to support the ability to continue to see patients and ensure access, but then even training programs. There are some primary care programs that are developing fellowships called digitalist fellowships, where it's a group of physicians who are really committed to understanding how to implement technology in their clinics. So one is curriculum reform and revision that reflects the growing role of technology, because in fact, our students are going to demand that. I mean, I watch my kids on any given day and how they use technology. It's fundamentally different from even how I do it, and certainly different from how my parents do. So one is building that technology fluency within the curriculum. And then how do you actually implement that in practice? It may be that there's a particular group of interprofessional clinicians who have technology-enabled practices that are able to be accessed from a whole community, or that those elements get diffused into individual practices. And we're looking at that. So curriculum reform, and then implementing reforms and practices that create a digital-first environment, right? How can we use elements of remote patient monitoring to identify early escalation of conditions? How can we take advantage, for instance, of radiology imaging, that if you apply generative AI, you can identify unexpected risk factors for cardiovascular disease that can then help us move upstream in the prevention space?
My understanding is that the AI reading of images is actually more accurate than a human being looking at something. That it's because it remembers every image it's ever seen and every anomaly in there. And in that education process, again, as a lay person, so many conditions present the same way. Yeah. They can be fairly, easy to deal with, and they can be very, very complicated. And I think we've all had family members or perhaps personal experience with thought it was one thing, it was something else.
Yeah.
And will this push to digitization and AI help winnow through some of those conditions?
Yeah, I think it's a great question. I think I think of three broad approaches to AI or generative AI in healthcare delivery. The first is, how can we use it to support operations in a way that allow our team members to work at the top of their particular area, right? Some of the processes that we have in areas like, revenue cycle or pre-authorizations, can we thoughtfully automate those to allow our team members to work on even more patient-focused activities? Second is coming back to your point of how do we support our clinicians in this incredibly changing time, which is how can generative AI reduce administrative burden in some ways for not our physicians, our advanced practice teams, our nurses, all of our team members. Great examples there, which include the ability to work within the electronic medical record to generate responses to, for instance, pharmacy refill requests. It'll help the patients because it may get done more quickly. It reduces some activities that allow our teams to focus on patient care. Really impactful has been ambient AI. Technologies that have been introduced so that you and I can sit in clinic together. I can listen to your history, do a physical exam, and a note is generated. Through that interaction, that reduces the time of documentation. We've seen excellent data, particularly at University of Michigan Health West and now here in Ann Arbor, that it's reducing the time spent in the chart for our physicians and finding ways to do that in a patient-centered fashion. But that reduces that administrative burden, is going to support our workforce moving forward. And then the last frontier is what you said. Can we use generative AI to support more precise diagnosis, better treatments? I think that there's a lot in that, right? Kind of understanding the data around reliability and consistency, how you keep a so-called human in the loop in some of those interactions. But I think particularly exciting is even on the research frontier, there's starting to now be AI to identify what we call previously undruggable targets in cancer. You can imagine a cloud where you have all the available therapeutics, all the available genetic changes in patients with cancer, and identifying new ways to match those. And I think that's where really generative AI is going to push the frontier of innovation in healthcare delivery to an even greater degree.
That is just, again, one of those very exciting things as we move to the future of humankind. And does that change the kind of person that is applying to medical school, or does it change the selection criteria? So how does the recruitment or the selection of medical students go, and what might be different about the journey of a medical student today versus perhaps during your time, your early training?
Yeah, I think there's so much has changed. A lot has changed in medical education, to how course materials are presented, to the timing of your preclinical work, to your clinical rotations. I think the fundamental issue is that embracing and applying technology is part of day-to-day life for the next generation of medical students. And so building curriculums to match that is going to be fundamentally important. In fact, I think it will be demanded of healthcare education across all of the medical and allied health professionals, that technology be part of that. I think that the commitment still to patient care, to understanding the information involved, will endure. But I think an embracing of technology and a willingness to apply it will be a foundational element of individuals who pursue a career in medicine. Now, I want to temper that by saying what I said earlier. Fundamentally, healthcare is still an essentially human interaction. And so that commitment to humanism, to empathy, to the idea that, when I walk out of my clinic and I see my patients there, almost all of whom have cancer, I know that what they would like is to get back to be concerned about what's for dinner.
Yeah.
But I will say this though, I think it is true, and I say this often publicly. My parents, for instance, may never embrace a healthcare system that's technology first, virtual first. I don't think my kids will ever embrace one that isn't. And so how we evolve that from both education to clinical care delivery to patient expectations to how we balance the art and science of medicine is the great opportunity in front of us.
And look, I'm in strong agreement with you. So by way of example, the ability to get a virtual appointment, right? So in the old school, it was your appointments at 10 a.m. So you have to drive to the clinic, you have to park, you have to go to the waiting room, you get seen, and then you get your follow-up. Or here you get a text that says the physician will be ready for you. Make sure you're in front of your computer in 5 minutes. And you get your exam and, okay, we think you've got shingles. I actually did get diagnosed with shingles. And we've got your pharmacy on record. You can go pick up the antiviral there, and I'm done in 15 minutes. Like, how much better is that? But in between the demand side of this, human beings seeking wellness, seeking diagnostics, seeking treatment, and this amazing digitization and all of this research, we've got a payment method. I won't call it a payment system because it's not a system. But let's break that down a little bit. We've heard a lot about Medicaid changes, and I've had people on the Common Bridge talking about we're going to have more underinsured and more uninsured. And as you sit down to deal with your budget, which is substantial, what impact do you see on Michigan medicine or perhaps academic medicine in general, given the dialogue around Medicaid?
Yeah, thanks, Rich. I mean, this is an incredibly important question. And I will say, first, there's a lot of discussion about affordability in healthcare, and I think that's an important conversation. I mean, that you mentioned the size and scale of healthcare for the economy as a whole in your introductory comments, and I think as healthcare providers, we absolutely have to be engaged in that conversation and accountable to thinking about affordability. And in many ways, that becomes, do we practice medicine according to the best available evidence in a patient-centered fashion? And what decisions do we make around when to utilize care in a particular setting or to order a high-cost imaging test, right? And I spent a lot of my early career thinking about that in the context of prostate cancer. How do we determine those patients who need aggressive treatments like surgery or radiation therapy? Or how do we identify those patients who can be safely monitored over time? The number of factors that converge around those decisions is multiple and complex, but that's part of the responsibility. I think when we think about affordability, we have to be focused in on appropriate selection of diagnostic tests and treatments, delivering those in a high quality fashion that avoids downstream complications and more costs, and then selecting cost conscious options when those are appropriate. That requires careful conversation with patients. We need to be involved in those conversations. At the same time, I don't think that healthcare delivery systems are the only element that contributes to those affordability conversations. Coming back to Medicaid, then, certainly elements of the reconciliation bill will affect our patients. First, we know that it is likely that there will be a decline in Medicaid eligible individuals in the state of Michigan, for instance. How does that affect us at Michigan Medicine? 40 to 50% of our patients in children and women's hospitals have Medicaid. Around University of Michigan Health Sparrow and the surrounding communities, anywhere from 25 to 35% of patients are Medicaid eligible. If there is a decline in eligibility, empirical data suggests more use of the emergency department, missing opportunities with preventive care, and so downstream more expensive scenarios.
So let's zoom out, okay, and look at the insanity that we have right now. We have amazing life-saving care. We have people that need it. And just as you said, your clinical workup says this is a patient that needs more aggressive treatment or maybe not so aggressive treatment, what it might be. But the reality is that person sitting in front of you, they're saying, well, this is a Medicaid patient and Medicaid won't allow us to do this. Or they're a commercial insurance. And by the way, the insurance companies have always been ahead with technology, and no doubt their AI engines are going to be geared to saying you can't have it because that's what they do. How do we get the payment system to reflect the great care delivery, diagnostics, and treatment with the demand without the administrative burden that you and all healthcare providers have?
Yeah, I mean, Rich, that's a fundamental question, and I think one that, first and foremost, that essential clinical interaction between the whether it's a physician, advanced practice team member, one of our nurses, and the patient has to be grounded in the best available evidence in selecting treatment options. That fundamental, contract, if you will, between the physician and my circumstance.
But there's a third person in the room.
Right.
But you say you need this.
Right.
But I got to go talk to somebody in Minneapolis about this.
And then I think there has to be dialogue and collaboration around a set of guardrails that allow that clinical judgment to be expressed more easily into the payment. And AI has created, you're right, this kind of ability to say yes or no in different ways. And, we work hard with our payer partners to understand what are the right indications for certain imaging tests and to smooth that pathway for patients. And I don't know that there's a simple set of criteria, but one, it requires demonstration of a commitment to evidence-based care. Two is open collaboration around guardrails within which, pre-authorizations can be more easily implemented, and then accountability and feedback. And I think it is reasonable on the clinician side to say, if you get data that you're outside of some of those boundaries, how are you going to work within your clinical teams? And there are some good examples of that in the state of Michigan, where partnerships with Blue Cross Blue Shield of Michigan have looked at issues like appropriateness of imaging and in other areas. And I think we need to keep building on those.
Yeah, indeed, it's complicated, but having that second guessing going on is the thing that is a dilemma that we need to unwrap. Maybe putting you on a spot.
Yeah.
If you could design an ideal payment system for the United States of America, what would it look like?
Yeah, that is a complex question. I think there have been some efforts to kind of consider payment reforms that focus on, for instance, creating lower friction decisions to pay for services in those areas that demonstrate the greatest value to patients. For instance, there's an initiative out of the University of Michigan called value-based insurance design that I think has some elements that would want to be incorporated in that. In other words, making it easier and lower financial and administrative burden to get the most effective therapies to the biggest number of patients in a way that improves health, which is really so some elements of that are likely to be important. Second is the fundamental concept that healthcare should be accessible, to patients who need it wherever they are and whatever their circumstances are. And that's a commitment we have at Michigan Medicine. So a focus on ensuring the greatest levels of access, lowering the friction to ensure that the most effective diagnostics and therapies are available, and then keeping that patient kind of physician or provider interaction at the heart. Those are the design principles. How we'd get to the more granular layers, Rich, I think we'd probably need another full session on that.
Yeah, well, when you think about it, the least friction is in the ER. All right, you come in, you present, you get triage, you're not a cardiac event, and then you wait based on your condition. And you might be turned away from the ER because you're not sick enough, you're not injured enough. And we need to get there. And when you think about something as base as primary care, all right, it's not, oh, my appointment book's full, we'll see you in 3 weeks, right? No other retail business works that way. It needs to be, I would like to see you, and we've got to turn that model around to say, I want to get more patients in, through using these technologies.
And if I could just make one comment on that, Rich, I think, some of my initial responses were related to that, the transactional elements of payments for classic, bricks and mortar healthcare delivery. What you're referencing, I think, is a really important part of designing a payment system, which is making sure that these innovative care delivery models are reimbursed in a way that there's transparent economics in the relationship between expense and cost. Because if we don't have reimbursement that supports virtual visits, that supports care at home in some circumstances, that supports the ability to access remote monitoring, then all those different channels of connectivity are limited. And it is through those different channels of connectivity that takes the I'm calling and seeing if I can be seen in 4 weeks to here's my circumstances right now. What are the tools available to me to better understand it so I can interrupt the progression or get answers to my question? I think your comment there really reflects the expansion, and many of those are in the midst of the policy debates in Washington right now. Extension of telehealth coverage from what we saw in the pandemic, some extension of different home-based care models. Those are really important questions because they broaden the lens of what healthcare delivery looks like and how it's reimbursed.
Indeed, and the amount of money that we waste with eligibility requirements, the amount of money that we waste on the dueling computer systems between the provider saying this is necessary care and the payer saying it's not necessary care. People getting gaps in their coverage. And, I think, in my humble opinion, the most insane part of this is having someone's healthcare coverage come from their employer. Maybe in my grandfather's time, who was 40-something years at Chrysler Corporation, it made sense. But, in today's gig economy, why would that make the least bit of sense? So I think there's a lot to be said about healthcare payment reform, and hopefully we'll get a chance to talk about that. But as you look back on your career at, which you've still got a long way to go, what's changed? And I can tell you're very excited about the future, but what's changed since you got in, and what should our listeners, readers, and viewers be thinking about in terms of healthcare, and particularly as it comes up to policy decisions?
Yeah, thanks. I mean, in many ways, Rich, when I look back over the last, I joined the faculty at University of Michigan in 2008. So over the last, 17 years, it's hard to underestimate the impact of the pandemic. And it may be routine to say that in some ways, but the impact of the pandemic on healthcare delivery was profound in several ways. First, its impact on the healthcare workforce, which still continues to be in recovery today, right? Staffing, recruitment into the fields, all the different fields of healthcare, supporting our staff and our team members and recognizing their great work, trust in the healthcare system and the relationship between patients and clinicians, that has ebbed and flowed in the time since the pandemic, and we continue to want to build, that fundamental trust that we're doing the right thing for our patients. Those have been very important. I think what has been particularly profound, though, has been the way that the delivery of care has changed as a consequence of some of the technological issues that were adopted so rapidly as out of necessity during the pandemic. And that really sits in the relationship between, for instance, the electronic medical record and care delivery. One has been the expansion of virtual care options. We talked about those earlier. In some areas, like next week, I have a clinic with many of my patients who live across the state where all we need is a 10-minute video-based conversation and they had a blood draw locally. There's no reason for them to drive 200 miles, and we know we've saved thousands and thousands of miles in expense for our patients. But that hasn't been the case in every single specialty. So where that virtual first option makes sense, where it doesn't, how you prepare clinicians for those different care delivery models and students for those different care delivery models was important. But one fundamental other element, Rich, has been what we call asynchronous care, which is all the ways that information arrives through portal messages, through requests. There are estimates that, for every hour of actually seeing a patient, there's been exponential growth in and that has had a real impact on our workforce, right? That is what our primary care physicians will say. Well, yes, I'm still seeing all the patients I see in clinic, and then I finish my clinic and I have really complex portal messages. So the implications of how technology has changed, what that means for how we educate and deliver care, that has been a profound change over the arc of my over the arc of my career and my time, and has really affected clinical care delivery. It also affects research, because that electronic medical record is a new source of discovery, and it affects how we train the next generation. As we mentioned, how are we ready to prepare for that asynchronous care? How do we use technology to support it? And then how do we connect across a bigger system? Because when I started, the University of Michigan was an academic medical center in Ann Arbor, one of the best in the world. We're now an academic health system across the state, I believe one of the best in the world. And how do we create consistency in areas like quality and safety, access, and patient experience that reflect the Block M wherever it is, while at the same time recognizing that the circumstances in Grand Rapids or Lansing or Ann Arbor are going to be different? Those are some of the changes I've seen and some of the opportunities we have in front of us.
Well, I hope that we get to a payment system that will let people access the wonderful world of Michigan medicine. And look, the fact of the matter is that had payment methods not been modified during the pandemic, most health systems in America would have gone bankrupt. And if there's ever proof positive that what we're trying to do makes no sense, that's it. But look, you operate in a very complicated world, and I appreciate you sharing the nuance and the beyond the soundbite and the headline. And you're also dealing in a social world that Michigan's been in the news around DEI. Michigan's been in the news around transgender medicine. Michigan's been in the news about making sure that the workforce is diverse, and people kind of want to go to a soundbite. But I don't imagine in your office or in your clinic these are soundbite issues.
Well, I think in many ways, academic medicine sits at a particularly significant interface between higher ed and healthcare delivery, both of which are experiencing the impact of external changes. Research funding for healthcare delivery, elements of diversity, equity, and inclusion in many of these conversations. Our focus has been, how do we continue to be an organization that lives its values every day, our core values of caring, integrity, inclusion, innovation, and teamwork, right? To have a set of strategic priorities that includes the concepts of belonging, access, safety, and quality and experience in a way that ensures each of our employees feel like they have the opportunity to thrive and reach their full potential. We are committed to resilient mechanisms to ensure that endures over time, because we believe that's what drives our mission forward. Each of the items you mentioned is complex and has multiple levels. Our focus has been to continue on transparency in our organization, support for our team members and our patients, telling the story of the good work we do. I think, Rich, I've seen data that if you go out and you do it, there was a survey done in the state of Michigan through the university, and it asked what are some of the biggest impacts of the university for you and your community. Michigan medicine is often at or near the top of that list, and I think we want to continue to be that source for the entire state, the most consequential academic health system in the country, moving our mission forward and bringing our expertise to as many communities as possible. I think if we do all those things, we'll be able to weather some of the changes that are happening around us. And again, continuing to be an excellent partner with communities, with the state government, with the federal government, most importantly, on behalf of our patients and our team members. It's not an easy equation. I don't sit here, Rich, and say that we've solved every element of that, but we're committed to the internal dialogue and to the support for our team members that are necessary in this moment in time and moving forward.
And the world-renowned and reputation as a research facility, a research organization, that if you have a particular case, you might be anywhere in the world. The best place to come is Ann Arbor, Michigan. Dr. Miller, you've been really generous with your time. This is really informative. Is there anything that we didn't cover, or any closing comments that you've got for the listeners, readers, and viewers of the Common Bridge?
Yeah, well, thanks, Rich. I'm really grateful. And, I want to start by just expressing my incredible gratitude and admiration for all of our team members at Michigan Medicine. I always say when you think of the clinical delivery system, we are a 24/7, 365 forever organization. There's never a moment when we're not available and ready to step in and help our patients and our community. Our research and educational endeavors discovers drive the next level of innovation and are a source of incredible pride and impact. And I want to acknowledge that. As we look forward, we see that the moment is challenging, but I believe our teams are built for this. And I'm so grateful to kind of lead and work alongside of our teams. We talk about our strong base. I mentioned those base priorities, and we talk about looking forward to more innovation, impact, like the story of histotripsy I told you, and really committing to the idea that if we can work at that interface between discovery and education and our clinical delivery, we're going to find new solutions to challenges that affect our patients, that allow them to continue living their lives well. And I think we are such an extraordinary asset in this community, in the state, nationally and internationally. I'm proud to be part of it. I want us to be held accountable to continuously improving, but I also want us to feel confident that this is a moment where we're going to move forward and drive impact in healthcare and education and research and for the public good.
We've been talking today with Dr. David Miller of Michigan Medicine, and I hope this has been encouraging to the audience of the Common Bridge, because the Common Bridge is about saying that there are solutions to today's problems if we only have the will to work on them. I certainly am uplifted by hearing about some of the miracles that are going on right here in the city of Ann Arbor, across the state, nationally and internationally. We have good people like Dr. Miller leading great teams of people to make positive change in our world today. And so with our guest today, Dr. David Miller from Michigan Medicine, this is your host, Rich Helpy, signing off on the Common Bridge.
And Rich, if I could just always say, I always have to close with this, which is go blue.
Yes, especially in this month.
Exactly.
Yes, indeed.
Thank
All
you
right,
very much.
Go blue.
Thank you for joining us on the Common Bridge, where we continue to seek clarity across divided lines. Subscribe and support the Common Bridge on Substack, YouTube, and wherever you listen to your favorite podcasts. Until next time, we invite you to stay informed, stay engaged, and help build a bridge of common understanding.